Tonight on Call examines rural health care in South Dakota.
Funding for On-Call television is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On-Call television as it continues to open doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by Dakota Care, the Brookings Health System, Dr. Mark Bubach with Dakota Allergy and Asthma, Dakota Dermatology, Aberdeen Asthma and Allergy, the Orthopedic Institute, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation. From the horse and buggy docks to the high-tech virtual medical care of today, rural health care has evolved in this country with changes that were never anticipated. We examine rural health care when the doctors are on call tonight.
I saw a country doctor, asked him what was wrong with me. What's called unaware, accidental and devil may care.
Hello and welcome to On Call Television. Tonight our topic is rural medicine. This is a chance to compare rural medicine to big city health care and to ask questions about the practice of medicine in rural South Dakota. What's the quality of life for one practicing out here? Why would anyone choose rural medicine, family medicine, over being a specialist in a city? What's the quality of care for those seeing a physician, PA, or a nurse practitioner out here? What kind of access problems do people have living in the prairie a long distance from the nearest hospital? How do you stay current in the science side of things if you're practicing here? What would make such a care provider tick? Tonight we have a rural family physician, Dr. Joy Faulkenberg. She was raised and is presently living on a ranch. She's highly trained and yet a generalist, one with the broad knowledge base required to answer or to start the process to answer all problems brought to her by the people on the prairie and from the Black Hills of South Dakota and the region around. Joy, let's find a little bit about you. You're originally from?
I am originally from Falkenburg land, I call it. I actually came from a ranch that's between Harrison, Nebraska and Edgemont, South Dakota. We could go about 27 miles to Harrison or 27 miles to Edgemont, and we live out on the Nebraska, South Dakota, Wyoming border.
Yeah. So you're a ranch girl?
Yeah.
Now, I mean, raised cattle, milk cattle?
Nope, just straight up beef cattle. Used to be
cattle.
Simmental, but now mostly Angus, black Angus.
And part of what you do is interesting is that your dad was a teacher for a while. Tell me a little bit about that.
So he was a professor actually at the University of, or at Chadron State College. And, you know, first generation ranch, it's really hard to get into ranching. And he drove, tried to support the ranch. My mom actually raised 5 kids on the ranch, and Dad supported that income by driving back and forth to Chadron, which was 70 miles one way. So that's a
long way.
That's a big feat, yeah. He actually had his PhD, and so he was big into education.
So, and one of the things he developed was a rotating grassland story. What's that?
Yeah, so he wanted to see how you could improve the land, and there was a theory at the time that there wasn't, that cattle would injure the land. And he believed that if the hoof action was proper and how the amount was correct, that it would be good for the land, good for the cattle. And so he intensely grazes an area for a certain amount of time and then rotates those cattle. And we do all natural beef too, so better for people.
So instead of a feedlot idea, this is rotating on grassland here and then moving it over here, and it's good for the land.
Right, absolutely. It's about 60,000 acres of rotation. So it's a big area.
A doctor of the land. So.
Exactly. Yep.
Yeah.
Yep.
So, and then you went to high school in?
I went to high school in Edgemont. I went to grade school in Harrison. We switched up because our headquarters of our ranch moved. So my sister, who practices with me, her children actually go to Harrison, Nebraska, and my nieces and nephews go to Custer, South Dakota. So we're kind of all over the prairie down there.
Right on that cusp of the South Dakota-Nebraska border.
Yep.
So, and then you went to college at?
I went to the University of Wyoming for a couple of years and then decided to transfer to the University of South Dakota when I wanted to go to med school. So the University of Wyoming is only 3 hours from the ranch. I had to go clear over to USD, which is about 9 hours away.
And they don't have a med school, I know that.
In Wyoming, right?
Right.
Mm-hmm.
They farm their kids off to somewhere else, which I think is a big mistake for Wyoming.
Yeah, I do too. I actually agree with you. I think that if you want to grow your own, you better keep them close by.
Growing your own. We'll talk about that in a minute, but let's talk. So you went to USD and then you went to USD School of Medicine.
Right, and as you know, the way that the School of Medicine works, first 2 years at Vermilion, but then you can choose to go back to Rapid City campus for me, or you can go to Sioux Falls or Yankton. So I was able to go back closer to home.
And you landed in Rapid City. Were you married at that time?
I got married my 4th year of medical school. My mom passed away my first year in medical school, and that was hard for me. I was really hoping to get close back to my dad.
Did she have cancer or something?
No, it's just she had a familial kidney disease, but kind of an unexpected death. Did not expect it at all. My second, third week in med school. It was terrible.
We're going to come back to this, but I want to ask you guys to realize how important it is to get your questions. The questions about rural medicine, about any medical issue. In fact, this is a broad-based mind here. She can ask and answer anything. The two of us should be able to figure any questions you call. So would you please give us a call? We'd be honored and pleased to have them about rural South Dakota and so on. Please submit them to oncalltelevision.com, or you can call the telephone number 1-888-376-6225. That's 888-376-6225 for your questions about anything, or if you want to talk about farming and ranching,
we can do it,
and medicine in this region of the world, and why a person would go into this. All right, so back to you, Joy. So you did med school in South Dakota, finished 2 years in Rapid City, and then you did a residency.
Yes, and so my whole goal was actually to go back to the Edgemont area. And Edgemont probably can't support, obviously, a lot of a big medical community. So Custer was kind of one of my loves because it's in the hills. And so I went to Rapid City for my residency, knowing that I wanted to end up in that area. I wanted to know who my physicians, my go-to people were. And that worked out really well for me.
So Rapid City, you farm out some of the residency in family practices in Rapid City and some is in Sioux Falls.
Yes.
And in Yankton.
No, the residency itself is actually all in Rapid City, except for pediatrics, where you go to Minneapolis and you go to Salt Lake City, and then you can choose to go to other places. You can go anywhere you want to. So I went to Alaska. My sister went to Oakland, went to the Knife and Gun Club area. We just went where we knew we could get really good training and come back and use it. Most of my really good training was at Rapid City, but to really get gunshots or really crazy surgical cases, sometimes some other bigger cities.
Yeah. You went to Alaska. Mm-hmm. What did you learn there?
Oh, wow, I learned everything there. I was in Juneau, so we were kind of landlocked, and we had to take care of the outlying small communities of like Hoonah.
Juneau is way the heck up there, isn't it?
Yeah, it's way down on the base of it, and you've got to go fly into Anchorage and then fly into Juneau. Okay. So it's incredible, and I learned a ton from Dr. Chu there. He was incredible. He actually did some holistic medicine along with Western approach, so that was really, really educational.
Okay. So, and then you came back and practiced in the Custer area.
Yep.
But you do outreach?
So initially I did an outreach in Edgemont, and then we had a hard time sustaining that clinic because of we were linked with the assisted living facility. The assisted living facility closed, and it was hard to keep that all running. But we have a Hot Springs practice, Hill City practice. I'm going to start going over to Newcastle in January, and then I practice in Custer. And so we kind of service that wide geographic area, sometimes all the way close to Chadron area, up to the Harrison border, Hill City.
Now, your clinic is independent, or you're owned by Rapid City Regional?
We are owned by Regional Health Physicians. regional health physicians.
And then, so how many are in your Custer group that does this rotation?
Custer is so lucky, Rick, because we have 5 physicians in our group.
In your 2,000 town. I mean,
Yeah.
I don't know of any 2,000 town in the state. I mean,
Yeah.
and part of it's because you've got a good group. I mean, it draws on it, doesn't it?
Yeah, you know, as a medical student, I went and I followed Terry Graber. He's one of the physicians there, and I remember thinking, I want to be just like that guy. He can handle anything.
I want to be that guy.
Yeah,
Yep.
he's so smart. He can handle anything. And then I begged my sister to come practice with me, and then we called Dr. Brown, and now I've recruited Dr. Waddell, and it's really a great group. We're really tight.
Yeah, Lisa spent some time with me when I was I can't remember whether she was a junior or a sophomore medical student or a senior medical student, but she spent time with me. And
She's smart and she's great. She's a great clinician.
Yeah, smart
Kind.
lady,
Mm-hmm.
kind lady. So let's talk a little bit about this whole idea of rural medicine. How different do you think your practice is? You've got a sister that works with you,
Yes.
but you have another sister who is a family physician in Palo Alto.
Yep.
In a big city. I mean,
Big
in
city.
the whole West Coast is sort of all together, right?
Yep.
So what's her practice like?
Well, she tells me that she's like overpaid and underworked. So if she watches this, I hope she remembers she said that. But you know, she said she's kind of she describes it as practicing for the rich and healthy. People will come in and request MRIs for their kids that fell off of the merry-go-round. She's charged with keeping people well, but they worry about a lot of things, whereas where I'm at, you have to encourage people to be concerned. They may stumble in with something and you're like, I'm really worried about this, and they're like, doc, it's fine. I'm like, I don't think it's fine. And then you're charged with explaining to Fred why it's not fine and why he really needs to do something. And you know, if it's gonna cost him $5, he's concerned about that. He's on a limited income.
This is South Dakota.
Yeah.
We're a land of deniers, particularly guys in South
Yes.
Dakota. I'm all right. I'm tough. you know.
That reminds me of a story, can I tell you?
Sure.
One of my patients' wives called in and she said, I'm worried about my husband. He won't come in, but he can't get on his horse. He's saying he feels nauseous and he gets sick. And I'm like, and he can't get on his horse?
Something's wrong.
Yeah. We ended up life flighting him out of there with, of course, an MI. You know,
Okay.
but that was
An
her,
MI, a heart attack.
Right, a heart attack. Yeah. Her presenting complaint was he can't get on his horse.
Yep.
Yeah.
I knew there's something
Yeah,
wrong.
right,
That's the
because
way it
we-
is in
yep.
South Dakota. So it's different in the West Coast, I mean, California. And so she ends up referring, I mean, they come in and this guy, some of the primary care is, oh, I see, you go over here.
Yes.
Oh, I see, you go over here. And it's a shuffle to the specialist,
Yeah.
right? I don't really think we do that as much here.
I don't feel like it. I mean, she seems like she's a little bit more of a coordinator, and she's an incredible physician, but she's a coordinator of care between specialists. Whereas there are a lot of times I don't either have access to a specialist or my patient says, you're gonna deal with this. I mean, even our new physician, Dr. Waddell, says the other day after he just started, he said, I didn't really want to fix this guy's finger, but he told me, you're gonna fix this finger because I'm not going anywhere else.
Yeah. So you pulled it and it
Right.
popped back in a line. The story though is that some people think that the best care is where all the specialists do it. What do you think of that?
I totally disagree. I think the best care is a doctor who gets right up close to you, touches you, and listens to you. You will never, ever get better care from any physician than the physician that sits down and listens to what you're saying. And the lifespan of knowing you, I can walk in a room without you saying anything, and I actually know 10 years of history because I know that person. I know what they should look like. I know what their family's like. I know why they're stressed out. And so I think that's good medicine.
I know that person always is pale. They always look like
Right.
that. Or that is new pale.
Right.
That's something wrong.
Yeah.
Yeah. I mean, you know, I'm at the phase of my life where I know all these people through all these things, and I have a patient who is in hospice. It's just breaking my heart. I mean, because I've known this man for 30 years, you know, and it's like my father. I mean, he was just this wonderful man.
But doesn't that fill you up too? Because one of the things I love about how I practice, I walk into a room and I get as much from my patient as they get from me.
Absolutely.
I just am filled up at the end of the day.
It's a wonderful
Yeah.
job that we have.
Yeah.
Different than the specialty things and the distributions. Practicing medicine in rural communities has been a norm for South Dakota. One retired doctor's experiences provide true insight to the life and practice of a rural doctor in South Dakota.
when we transferred, and I say we, my best friend through pre-med was Bob Blumendahl. But one of the bonuses of knowing Bob was that when I did my sophomore preceptorship, the last month of my sophomore year, you spend with a family doc somewhere in South Dakota, and that still happens. And I spent my time with his father in Ipswich. He was truly a country doctor. First morning I was there, I lived right in his home with him, so I was part of the family for that month. Got a call to go out in the country that a man who was very sick, and we got to the farmhouse, and the first thing we saw was a pool of blood in the farmyard. And it turned out that he had a bleeding duodenal or stomach ulcer. We don't see much of that anymore, but at that time we did. And we were able to get him to the hospital and give him some transfusions, and his outcome was good. But that was my introduction to clinical medicine in South Dakota. Another thing that happened in Ipswich was Doc Blumendahl went somewhere for the weekend, so I technically was on call, but there was a doctor in the next community that sort of I could call if, you know, whenever we needed a little bit of help. So a lady came in labor. Her second delivery, she'd had one baby already, so this wasn't the first time. So things progressed rather rapidly. And before the doctor could get to the hospital to help me, why, the nurses sort of held me up while I delivered the baby. And that went well too. So, and in Brookings at that time, there were surgeons and a pediatrician and internists, no obstetricians, but I was the seventh man in the clinic back in 1961 when I started. And so my house calls were somewhat limited, probably not further than 10 miles out of town, but we did make them when necessary. And of course, a number of times we would see a sick child or someone who wasn't able to come to the clinic, we would not hesitate to go to the house to see them.
Well, that's beautiful, Bruce. Bruce was my mentor.
Everybody needs a good mentor.
Yep, you look at the wisdom from this guy, and I leaned on him heavily when I first came. And then you kind of grow, and eventually, now at my stage, I think some are leaning on me a little, not much. So we have questions, which we truly appreciate. Join our conversation. Call in your questions about tonight's topic or any question of any kind. 1-888-376-6225, or you can email them to questions@oncalltelevision.com. And we have one that says, Indian Health Service has difficulty getting quality physicians like Dr. Faulkenberg. How can Indian Health Service recruit and retain good physicians? You probably know more about this than I do. In fact, I know you do.
Yeah, you know, I had some experience with this because my sister, Jolene, thought about going to Pine Ridge. Her family's from that area. They have a ranch in that area. And she interviewed at Pine Ridge and looked at that situation. I know that, for one thing, the just throwing money at it won't fix the problem, because physicians need support. And so if there's just a physician doing it, they just get burned out.
Yeah, you're dead.
Yes, and so
you run away.
I think a lot of it has to do with you have to lift the whole system up. In our neck of the woods, you know, one of the areas you see problems with is just, since the Indian Health Services has a harder time maintaining physicians in their practices, everything flows to Rapid. Whereas if we could keep a little bit more in those rural communities, which those rural communities deserve, then we could do it. You know, I think the key is education in the schools. If we can get those kids so that they see a mentor and they believe that they can go to medical school and they too can be doctors, then we will get Native Americans that go back to their Native American communities. And that's what it takes.
Well, it's
a personal mentorship.
Personal mentorship. Well, talk about growing your own, homegrown. Explain that a little bit more. You
know, the way I think about it is most people go either back home or they stay where they're going to be at. You know, if you stay at a residency for 5, 6, 7 years, you're going to probably stay in that area. And I just don't think that people can have an appreciation for Edgemont, South Dakota, unless they grew up there and they really love it. And the people are so great there, you want to return there. So I think that coming out of those areas can be intimidating, going to college.
Yeah.
You go to college and they're like, wow, even if you were a valedictorian, it's a step up that's huge.
That's a big thing.
So I think if you prepare them and they have somebody that they go to their clinic and they say, I spent time with Dr. Faulkenberg, I know what her practice is like, and I'm going to put forth the effort, and I'm going to do it. But we gotta grow their own. We gotta grow them.
Well, and I think it speaks hugely to the idea of South Dakota making sure that we have a quality medical school and we recruit our kids from South Dakota and or the surrounding regions, because this is where they're going to go practice.
Yeah, absolutely. Absolutely.
And so, but there's a fear that if you train them, they'll never come back to a small town because their spouse and lifestyle. And what's your comment to that?
I think actually, I would think the opposite way. When I bring med students into Custer, we go around the grocery store, they're with me. We go to Subway, and they are amazed. Everybody knows who you are. Everybody is supportive of you. My patients bring me apples so I can make apple crisp. They bring me pies. They bring me
carrots.
Gifts, candles.
I get a lot of good carrot.
Yeah, I mean, they love me. And my medical students said they have never heard in a physician practice so many people that came in and they said, Doc, how are you doing today? Is your family okay?
Yeah.
Are you doing all right?
Yeah.
They're like, your patients love you as much as you love them.
Yeah.
I'm like, that's cool.
But how do you beat that?
Yeah, so I think that once you submerge the kids into that when they're young, they want to come back to it.
Well, it's very important. I do know that there's data, and we may show that later. I don't know if we've got that promotion piece about where the younger physicians are in South Dakota compared to the rest of the country. We have more physicians younger than 55% than most of the states of the country.
Well, I'll tell you, I came back to this area. One of the things that allowed me to come back to the area is that I was on a rural health scholarship. And so the state of South Dakota paid for me to go to a, quote, underserved area. And what that created, and I've not talked to any of those people, I wonder if they figured out that they put me in an underserved area, and now we have made it 5 physicians in a 2,000 group practice, and we serve a huge
anymore.
Right. We serve a huge geographic area.
Yeah.
So if you have, there is definitely a minimum amount of physicians, because you can't take call 24/7.
No.
So you almost have to put a couple of docs in the area, and then it supports its own. But it burns them out if there's too few.
Right. Well, and it's that energy that you brought, and your mentor brought to the practice that makes it work. It's sort of like wanting to be in a club.
Yep. It congeals.
It's you get support there. That the picture I was just talking about will come at the end of this next package. So watch for that. We have a caller from Rapid City. Comment received Armour, South Dakota, small hospital, received the best care hospital of 2004. Did you know about that?
Did not know about that.
I did not know that, but
doesn't surprise me.
Good for
them.
Armour. We appreciate small hospitals and the efforts that small hospitals make. They have to reach a certain level of requirement by jumping through all these required hoops if you're going to provide care for Medicare patients, in fact.
I tell you what, my nurses, I was just on call last night. I got off this morning at 8 and drove over here. My nurses are the best, not just in the clinic, but in the hospital. Those gals, last night they're working with a demented patient. At the same time, they're working with a septic patient. At the same time, we get a gentleman in that's young, and we've got to intubate and do a resuscitation on, and they can do anything. They can multitask. We don't have a unit and a ER. They are everything, and they're amazing.
Yeah. Well, I could say that they're probably the second best nurses of the state of South Dakota, because boy, does Brookings have some great people. Here is Custer, South Dakota call. The Custer Clinic has expanded in number of physicians. Will the hospital and clinic expand?
Well, we had an expansion on the table, and what happened is the bid came in almost $2.5 million over. And so we were very excited because we brought a new physician on, and we're excited to move into our new building that we thought we were going to dig dirt on about 6 months ago. So now it's kind of up to how Regional Health Physicians works with Regional Hospital, works with the Custer Inc., and we're kind of trying to regroup. The physicians would love to see a bigger facility because we just have a hard time physically getting all the patients through. But on the other hand, you know, we will deal with what we have, and we'll continue to do really good quality care with what we have until we get something new.
Great. Here's a person who called in, had a cold 4 weeks ago, sinus infection, now has a sore neck. Could this be meningitis? What are the other symptoms? What do you think, Joey?
It more than likely, I would say that it's not meningitis, but here's what meningitis would look like. If you have a stiff neck and you have a fever, and you're getting, you know, much worse, you need to go in and be evaluated.
And that's not a well, tomorrow.
Oh no, that's like a right now thing.
That's a right now
yeah.
thing.
If you're a little achy and your back aches a little bit and you've got a sore throat and your neck kind of hurts because of that, that's probably part of a viral syndrome, because most sinusitis are viral and they last up to 2 weeks.
Right, and most of the time, I bet you that this person from Sioux Falls got an antibiotic, but
right.
shouldn't have, or it didn't help them. I mean, they say that you've got sinusitis if you've got pus coming out of your nose,
right.
You've got a fever, and you've been sick for 2 weeks or at least 10 days, and there's pain focally to one of the sinuses, then an antibiotic will help you one person out of 6.
I'll tell you what, I bet we're on the same page with this. With the rapid expansion of urgent cares, bless the urgent cares for being readily available, but right, the overuse of antibiotics in this country is staggering. And we're getting C. difficile colitis out of it, and we're getting antibiotic resistance.
What is C. difficile colitis?
You know, you get that diarrhea, you've got blood in your stools, you can actually die from it. Pediatric cases die from it. And it's because people come in and they pressure the doctor into saying, they come in and say, I want an antibiotic because I'm sick, rather than saying, doctor, this is what my symptoms are. What do you think? With, you know, we've got quite an education behind us. That doesn't mean that we're not willing to listen. I'm willing to listen to the patient,
right.
But it needs to be a team effort.
I want to make absolutely sure that I do the very best for them, and they think that they know, they've heard this enough.
Right.
Oh, you're not going to give me the antibiotic, are you? Because you want to hold it back, and I am really sick. You're not trusting me in the. I always know that I get better when I get the antibiotic. And the answer is, trust your doctor on that. You know, or.
You know, I read a study, and I think it was interesting. I find that if I really educate my patients, and I say, right now, you don't need an antibiotic, and this is how it could hurt you. If this happens, and this happens, I will write you a script, because the patient's always upset that they have to come back for a second visit. It's a double-edged sword, right? Sometimes I see people and they've used the antibiotic for something else. I'm like, why did I write that script? But there's some people that can be very trustworthy and follow the guidelines.
Don't use this unless you absolutely have to, because of these reasons.
Yep.
Yep. Good. I do that too. The Sanford School of Medicine at the University of South Dakota developed programs for interns to specifically practice in rural health, reaching small communities across the state and giving them a breadth of experience they cannot gain elsewhere.
And this is a very important part of what we do. It's one of our key missions. And of course, it's a key aspect of South Dakota. A lot of our population lives in rural areas, right. But it's hard for them sometimes to keep a physician. So we have several activities going on, one of which is our new Frontier and Rural Medicine Program, and the acronym for that is FARM. That's where medical students will spend, some medical students are going to spend their formative clinical year in a town of less than 10,000 in South Dakota. And we have chosen several towns for this. We have Millbank, Mobridge, Parkston, Platte, and Winner are the communities that we've started with. Each will host 1 to 2 medical students. Now, that's an important thing, because these communities have a lot of clinical experience.
Right.
They have a hospital, they have talented providers, and they have enough clinical material to give a fabulous education to students. This was funded by the state in the hopes of creating a pathway for rural physicians.
Right. And quickly, how have we done compared to other medical schools in providing people the wish and the desire to go into primary care?
Into primary care, we are 40% of our class goes into primary care. We are routinely at the top of the country, in the top several of the country. In rural medicine, we're actually close to the 99th percentile. We're always a U.S. News and World Report top 10 in the country for our students going into rural medicine. So it's something that our students come to us wanting to do, and we provide the opportunities for them. We are starting a rural surgery residency program. Again, we said 4 years of medical school, then you have to do a residency. The ones who want to do surgery now can do it in South Dakota. with an emphasis on general surgery and rural surgery, so that these people, when they come out, would be appropriately trained to go into rural, broadly trained. I mean, they'll be doing appendectomies or C-sections or anything. And that's actually not the case in many residency programs. So at all levels, we're trying to respond to the need for rural physicians.
The lighter areas defined the younger doctors. We have younger doctors in the state of South Dakota. That amazed me. I thought we're in deep trouble. I think the country's in deep trouble. The problem has for a while that everybody was going off into specialty care, and we have to turn that around. And I think the country is realizing, I mean, there's been a trend. Mm-hmm. Have you seen that?
Yeah, you know, what I notice around Rapid City is if the family practice residency in Rapid City stays strong, they'll put out family physicians that stay in that area. I mean, out of my classmates, I think of, you know, Lee Bailey and Chris Fromm and Patty Stevens that was there, and Dr. Lemke from, another from. I mean, there's just tons of them in the Rapid City area that the residency put out. And so the residency is vital to keeping the young people in that area.
Yeah. Well, they talk about the fact that med school is very important, that you take homegrown, and then the next step is that you have a residency that's local, because the highest chance of them staying in the area is through the residency. And I know that our numbers in South Dakota are higher than almost every other state, really, for kids staying at home. I mean, did you know that those numbers are good?
I didn't know that, but it doesn't surprise me. Yeah, that's great.
So we have a question from Sturgis. Caller wants to know about the breakdown test of LDLs. Do big and small particles make a difference in strokes and/or heart disease, and if so, how? So what's your take on that?
Well, you know, it's interesting, right? You can go all the way up to a lipidologist and then all the way down to a GP or a family physician. And what I generally go on is, I don't do a lot of the more fancy tests. I go on LDL, and then based on the Framingham study, right? What's your family history? Are you a diabetic? Have you had heart disease? Have you had strokes in your family? Are you male, and what age are you? And then I follow those criteria. I don't really find a role for the expensive homocysteine, CRPs.
I don't think there's been any data that shows that it changes anything.
Right. It's expensive medicine, and I think that in general, you know, if you follow the guidelines that we currently have, I have people come in all the time and complain about statins, and they'll say, I read on the internet, and I said, how many people do you see around you dying of heart attacks? How many people do you see dying of strokes? Number 1 and number 3 killer, right? If your doctor recommends a statin, you better seriously think about it.
Well, and I'll give you my take on it, though. I have to say, lipidologists, I know there are specialists who just spend their time, well, a lot of endocrinologists. I mean, they're honing in on this. But the science on primary prevention is pretty weak. I mean, the studies that say that it makes a difference are primarily done by the companies that are promoting the drug. And I do believe that if you've had a heart attack, or you're high risk, it's worth considering. But there's so many side effects of those darn drugs. So
there are a lot of side effects, and you know what I have to, and I'm sure you're better than most. How many times do you see a patient come in and complain about something, and a doctor really just discredits it right off the bat? You know, they're like, couldn't be the med.
Yeah.
Oh, come on, guys, like, right? You gotta listen. There's a lot of side effects from medicines. That's true.
That's true. And I will say this. So why don't we, as physicians, encourage them to change their lifestyle more? I mean, if you can prove that a doctor hammering on smoking actually is the most important factor in changing a person's lifestyle of smoking, why can't we encourage people to exercise more and get out of that couch and get moving?
Well, part of the problem, right, is like we're losing out on the art of medicine as things are like, you got to move faster, you're trying to work on your EMR, you're trying to
time with them. Yeah, that's right.
So we're losing out on some of the art of medicine. I mean, one of the things I love about my practice is I can figure out how to encourage people based on who they're hanging out with. So if I know Mr. Smith had a heart attack and I see Mr. Jones, who's his neighbor, next time Mr. Jones did, I'm like, you
got to talk to
your buddy just died of this, right? So you better put down the 6-pack of beer and like go for a walk.
Okay, there you go. Well, all in knowing your people and living in a smaller community. Here's a call from Oh, this is from a specific person. Hi, Dr. Joy. What has been your most rewarding moment in your career? From Carrie Moore in Custer.
Oh, that's really cool. I'm glad Carrie called in. You know, I have to say that I really have an affinity for hospice and dying patients. And by far, like, one of my most rewarding of all-time career has been recently. I took care of a dying patient, and because they were our neighbor, my daughter would go over and visit with me, and we would hold his hand and talk to him, and Nancy was there every night to do that, and I thought that was really great.
So it was a double, you know, it was a gain for your daughter.
Right, because she's going to learn how to be compassionate and empathetic to people, and I think that's great.
Oh, that's a beautiful story. Rapid City. In the past, the caller said there were about 1 physician for every 200 people in rural areas. What do you know about the ratio now?
I don't know that.
And you know, I do not know that number. It used to be that we in South Dakota had the lowest ratio. I mean, we had the least number of doctors per patient, per 100,000 patients compared to other places. And at the same time in South Dakota, this was when I was at Emory in Atlanta. At the same time, we had the longest longevity.
Oh, yeah,
People lived the longest in the state of South Dakota, had the least amount of doctors. I wonder if that means that if you have less doctors, you do better. You know what I mean?
Well, interesting. I always think to myself when people come in, what makes them live so long?
Yeah.
When you look at it, what do you see? People who grow their own gardens, people who eat natural foods, people who stay away from processed foods, and people who work hard.
Work hard. Physically active.
Yep, exactly.
Exercise. There was a 100-year-old man. He was in the Brookings Register about a year ago. He died after his 100th birthday, and he said, I think the whole thing is the fact that I walk 2 miles every day. And he's 100 years of age, and he's walking 2 miles every day, and then his life suddenly was over. I mean, it was the perfect life.
Yep. I have a 104-year-old patient that he's never taken one medicine. He fell and broke his femur. And we put him in the hospital, and they said, are you really going to keep him in the hospital as a swing bed for 8 weeks? And I'm like, yes, because this gentleman has never used anything out of the system. He deserves that, and he's back at his house. 104.
104 living alone.
No medicines.
Wow. Aberdeen, thoughts on narcotics used for chronic pain?
Hate him. I hate him. I hate him. I hate him. I hate him.
And it doesn't help them much. I mean, they just get hooked. And then they have the same amount of pain in the end.
Yeah, I really believe that this is going to come full circle. So we went the distance where we said it's a 5th vital sign. You have to treat pain. Doctors undertreat pain. Well, we were really talking about cancer pain, right? We should have been talking about end-of-life cancer pain. Treat those guys. Give them as much as they need. Nobody should be at pain at the end of their life.
Right.
But people with back pain, migraines, I really believe it upregulates the receptors, and it gets into this vicious cycle.
We had a Carol Miles, a neurologist, who's a headache specialist. I mean, been everywhere, read everything about it. That's exactly what she says, Joy. Same story. Here in South Dakota, talk about psychiatric care in the rural area.
I wish we had some more counselors, right? Because there is a need for counseling and behavioral modification. So I can do...
And you can do the drugs.
I can do a lot with drugs.
How much time do you have to listen to them, which is probably one of the major things that we need to do.
I mean, we have a high rate of suicide, and I was just telling some of my administrators that one of the reasons that I cannot be distracted by my EMR and I have to keep in focus is that the other day I noticed this guy was really sad. He was in for a diabetic check, but was really sad, and he was thinking about suicide. Yeah. If I would have been distracted, I wouldn't have caught that. But I just noticed there was something wrong.
Yeah.
There it is.
You
can't be distracted.
We were talking in our noon conference today about the value of intuitive thinking.
Yes.
Well, how do you teach a kid intuitive thinking? How do you teach a med student or a resident that? How can you say that there isn't a scientific, I don't have a scientific basis to say why I got from 1 to 4 without crossing 2, 3, and I got there because something.
Yep.
And we need to have that. You need to listen to be able to have that.
Yep.
Here's a question from Aberdeen. What is your opinion about hospitalists and the fact that hospitalists don't know their patients? I mean, you take care of your patients in the hospital.
Right.
You have an opinion about hospitalists?
I do. I understand how the concept came to be. But in general, and I'm sure there's going to be people that are upset with this comment, in general, when we moved over to a hospitalist system and we changed from one doctor to the next, we lost something with medicine.
I know we did.
We just did. And,
And I don't know the answer.
I don't know the answer either.
And it's a tough thing. But
Not everybody lives in Custer, right? I mean,
No.
if you were in Rapid or Sioux Falls or...
that's what's going to happen.
Yeah.
But not in Brookings
Right.
either. Whatever the level of technology a physician may have at hand, it still comes down to his or her skills and experience. There are moments when one does their best and hope that it's enough.
Since the 60s, the ambulance services have come a whole 90 degrees from throw them in the back of a pickup and get them there to full EMTs, paramedics now, helicopters. When I first started medicine, we would throw the back seat out of a Piper Cub and I'd jump in there with my patient and we'd fly through the night. Now we got the specialists coming in, the specialists trained with the helicopter, fully equipped. I didn't see that 30-some years ago when I practiced. I mean, we did it by catching by God, you know. I remember I had a baby born with hyaline membrane disease. The only thing I could do for him was to put him in a double box and heat up some bricks and made a little bassinet and got him out. Now, today, I push a button, the TV screen comes on in the ER. I've got the specialists from the main center telling me, do this, have you done this? Do you consider this? The helicopter's on the way. That's all I have to do. I don't have to pick up the phone, beg somebody to take the patient.
It's better.
That's where we've come. That's reservation in any place in the state.
We have a question from, I want to comment about Amiel Redfish's beautiful story. I mean, he wept, I wept.
Yeah.
During that story. I mean, you know, things are different. But and your comment was, but you still have to bag them. Tell me that.
Oh, I still have to beg for somebody to take him.
Oh, you have to beg.
Yeah.
Oh, I got it.
But I have to beg him too. I mean, we've got difficult airways, but we've got difficult airway kits, and we've really put together nice. We have to take care of them until, and a lot of times in Custer, the helicopter can't come because of the fog, so we don't depend on that.
No, you've got to be able to do it.
Yeah.
It is an important thing that you know what you're doing.
Yes.
You told me last night you intubated somebody. What's that story?
You know, I was actually going to go to church and see the kids, and when I went down, I saw behind the burger and bun place that there was somebody down, and I went over there just to see if they were waking him up. They weren't just waking him up. They brought him in, tubed him, sent him out, and he's doing okay. You can get anything there. I mean, we can be calm, and then all of a sudden somebody comes in with their neck slit in half from their motorcycle that somebody just put in a car. They've been gored by buffalo. They're having chest pain, and they were just standing outside. We get a lot of like drop-offs at the door. There's not a lot of times that people call the ambulance. A lot of times they'll come, and what you see at the door is they're going down at the door.
Right. I'll never forget a mother coming running into the surgical ICU at Grady Hospital. This is in the inner city of Atlanta, right? And I'm a senior medical student, right? And it was the night where all of the residents were gone, and they were being covered by they were being covered by the attending.
Oh.
So the attending. So here we are, the head of plastic surgery, the head of general surgery. I mean, you know, this is staffing the surgical emergency room. Here's the medical emergency room. The mother ran into the wrong place. She should have gone into the medical, right? She had a little baby that had tripped over a wire, gotten electrocuted, right? She runs in with this baby, and she plops it. She runs up to a doctor who's standing there. Help me, help me, help me. My son is stopped breathing. So the surgical head of the surgical ICU, no, not the head. I mean, the plastic surgeon, the head of plastic surgery, that starts resuscitation.
Right.
And we get the little baby back. I mean, I weep thinking about that, and the guy got done, and he wept.
Right.
Oh my God! I actually was here, and you never know what's going to pop in.
The physician's assistant student who came with me the other day, we started our day, and 3 minutes into our day, an anaphylactic patient shows up in the clinic. Emergently take him upstairs, epinephrine, the whole deal. Didn't have to tube him, but had to do everything epinephrine.
Anaphylactic, an allergic reaction, no blood pressure,
right.
just dying there.
60/30, right. Right on the heels a guy comes in telling me he ate an apple that must have had something on him and he can't feel anything, and he's going down with organophosphate poisoning, right? In the process of all this, we have a heart attack. In the process of that, throughout the day, I saw 12 in the ER and 40 in the clinic, just up, down, everything. I mean, it just,
so the med student said, oh, this was just a normal day for you, Dr.
Yeah, he was
Faulkenberg.
like, wow, I learned more in this one day than I've learned in about 4 weeks. Am I good? That's what rural medicine's about.
That's what you're here for. Here is from Rock Valley, Iowa. What is your opinion on taking an antibiotic before a dental work because she has had a hip replacement?
Yeah, you know, they seem to keep going back and forth on that. Again, I find it hard to believe, seriously, that a gram of Augmentin is going to prevent a full-blown infection. And quite frankly, they've done studies showing that brushing your teeth really hard probably has the same amount of bacteria in the bloodstream. That being said, you have to go on your college's guidelines, and the college's guidelines say to do it.
And the risk of the Augmentin, I mean, or the amoxicillin or whatever it is, I mean, it depends. So there's a risk there too.
Right.
It's almost worse with the antibiotic, but there's a risk either way. Here's a caller from Brookings. Pain in your lower back shoots to the hip and groin. What could this be?
So it could be a couple different things, depending on your age, depending on if you had some trauma. You know, the worst things we always want to rule out are malignancies. It doesn't happen very often, but I had a guy with prostate cancer. If they leave out that little part of their history, they can have an impinged nerve because there's metastasis to the back. But what is it a lot of times? A lot of times it's a pinched nerve, and they traumatized it scooping shovel or snow or doing something, and they've got to go in and see if... Don't go in and request an MRI.
Please.
Just go in and give the data, and your doctor will decide whether you just need some anti-inflammatories or whether it's something more serious.
Or give it a little time.
Exactly.
But the reality is most of those will go away. If you take them to surgery, 80% will get better. If you don't take them to surgery, 80% will get better. And it'll over about the same time. Here's a call from here, and what is your opinion on expanding Medicaid in South Dakota? Joy?
I actually stood up at a meeting. It was unpopular, I think, with the hospital. Most of the hospitals want Medicaid expanded. I personally don't want Medicaid expanded. In fact, I think they should come in, they should look at Medicaid, and they should actually make people accountable for why and when they're coming in. I think there's a complete overutilization by Medicaid patients, inappropriate use of the ER, and that they need to actually take accountability for Medicaid patients. Some people use it appropriately. The vast majority that I see do not use it appropriately and should be held accountable.
Okay, well, my comment is that I echo they should be accountable, but the system that we have leaves so many people who are the working poor that don't have coverage, and it breaks my heart. So I'm on the other side, Joy, but
right.
Hey, we disagree. Sioux Falls, caller had a stroke that affects right foot. Is there hope? Does he have to live like this? The stroke affect the right foot. Is there a hope?
There's always hope. I had this patient who had a stroke and his whole right arm didn't work, and they sent him to me saying, you know, looks like a permanent deficit, and that guy told me, I'm going to move my arm, and I saw him 8 months later, and he's like, look.
Now, I had a guy, I used to shake his hand, there was nothing. There was nothing there. He was lost it.
Yep.
And 2 weeks later, it was still nothing. And months later, I had to take my ring off because he would shake my hand so hard because it hurt my...
I'm going to tell you a stroke story, and I want all the viewers to listen.
We have no time.
Oh,
I'm sorry. We'll be right back after this.
The flu bug is getting ready for another season. Are you? Get vaccinated, because stopping the flu starts with you.
In Robert Frost's poem, The Death of a Hired Man, Mary and Warren sit on the back porch steps talking of their old hired man who this night returned to their farm in his last dying days, promising to work again. It's then that Warren speaks to the value of having a place to go, he says. Home is the place where, when you have to go there, they have to take you in. The same goes for having a medical home. As a kid growing up in rural South Dakota, I knew my doctor. And for our family, he would give our immunizations, sew up our lacerations, treat our sore throats, help relieve our pain. He would even be there to support us when we were struck with impossible tragedy. His was a place where when you had to go there, he would take you in and do his best to help. I didn't realize at the time how extremely valuable access to health care could be. Years later, in an Atlanta hospital, as an intern, I rotated onto the team that had to face vast waiting rooms of patients, some waiting more than 12 hours. I remember one fellow intern who bragged about seeing 45 patients in the less than 3 hours. It's hard to call that access when you get less than 4 minutes with a green intern for a medical problem that was trouble enough to cause you to wait that long. Still, many people in this country, especially those without insurance, have access to health care only through an extremely expensive emergency room somewhere. There they wait to see a complete stranger who must see them as a liability risk, and thus is encouraged to order every expensive test. However, in the end, the ER doc's hardest and most important job is to find somewhere or someone to take that patient in follow-up. And what's worse, too often there is no one to take the handoff, no medical home where the patient can go. Too many are medically homeless. I believe that in our society, every person should have a medical home. And until then, healthcare costs will continue to rise and quality will continue to be inadequate. So far in rural South Dakota, most of us still do have a medical home now, oftentimes, however, a PA or a nurse practitioner and a doctor team. And we should realize that it is something of extraordinary value. After all, everyone needs a place that when we have to go there, they will take us in. Okay. Well, we've got some more questions, Joy.
Great.
Black Hawk, RN, been around 69 years, says to give the patients more credit. Any comment?
I'm not sure what that means. Maybe she means we should listen more?
I think that's it.
Yeah.
And I think, you go, oh yeah, you've got this, oh, you've got that. I think the reality is they come in and they've got a complaint and you go, oh, I don't know, I don't have an explanation for that. Here's a pain medicine, bye. I think we really need to listen more. I think that's exactly it. Here's someone, what is the practice mileage radius that a rural doctor or doctors can service? Do you have a...
I think that it's just as much as they can do, and I think that it depends on how young they are. I think it gets harder as you get older to take call and, to keep up with it. But
and that's this question, how hard is it to balance motherhood with being a physician? How much help is your husband with that when he isn't dancing for videos in elevators?
That's hilarious.
That's a good story.
My husband was on a video for Gangnam Style.
Oh, is that right?
Fabulous. But he's also, my husband's incredible. He stayed at home with the kids for 5 years, and now he
He's
practices.
a lawyer?
Yeah, he prosecutes. He wants prosecuting is what he does. But I think you've got to make it all work together, and you have to work with your spouse to do it, because I can only be a good mom if he's a good dad.
Caller feels medicine has lost all closeness between patient and doctor. All they do is look at laptop. Is this good practice?
It is never good practice just to look at your laptop. And I sympathize with that patient because I think that it's really hard for doctors. But we are just kind of learning this too. And so as we get better, it'll get better. Yep. I mean, I still come in the room, put my hand on the patient, talk to the patient, because I don't want to lose that either.
No, and I'm with you. Here's a caller from Spearfish, Barry Smith, a classmate of mine. He said, Faulkenberg, personality, family medicine. Thank you, Rick, for the program. Great. Here's from Custer. Thank you, Dr. Faulkenberg, Dr. Joy. I think I'm going to move to Custer. What a great lady. This brings us to the end of our show this evening. I sincerely thank our guest, Dr. Joy Faulkenberg, for helping to answer all those insightful questions from our audience tonight. Sometime around 1900, Thomas Edison predicted The doctor of the future will give no medicine, but will interest his patients in the care of the human frame, in diet, and in the causes and prevention of diseases. Until next time, stay healthy out there, people.
Funding for on-call television is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On-Call Television as it continues to open doors for important medical information.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by Dakota Care, the Brookings Health System, Dr. Mark Buback with Dakota Allergy and Asthma, Dakota Dermatology, Aberdeen Asthma and Allergy, the Orthopedic Institute, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.